For slide number 12, Gaucher's disease. Now, you have already finished the chapter on genetic disorders. Can you still remember the enzyme that is lacking in Gaucher's disease? The glucocerebrosidase. Now, glucocerebroside is a normal component of the cells of our body, but it has to be also regularly degraded. Unfortunately, in individuals with Gaucher's disease, their macrophages do not possess the enzyme capable of degrading glucocerebroside, so that after engulfment of glucocerebroside, because the lysosomes of the macrophages do not possess glucocerebrosidase enzyme, okay, the glucocerebroside will accumulate in the cytoplasm of the phagocytes. That is why the phagocytic cells will appear large, and then the volume of cytoplasm will also become increased, which will lead to the enlargement of the entire cell. That is so because of the accumulation of glucocerebroside inside their cytoplasm. So those are called the Gaucher cells. So they are actually enlarged macrophages which have accumulated glucocerebroside, secondary to their inability to digest or degrade glucocerebroside. So those are the characteristic diagnostic cells for Gaucher's disease. They are called Gaucher cells. So enlarged macrophages with accumulated glucocerebroside. Okay, for orientation, that's the low power magnification view. Those are the Gaucher cells. So we are looking at the red pulp or the white pulp of the spleen. Okay, that's a white pulp, and then the entire thing will now be the red pulp. The spleen is actually red pulp minus white pulp. Okay, the entirety of the spleen is composed of red pulp, and then when you will be able to see lymphoid follicles, they are now the white pulps. So majority of the macrophages are located in the red pulps of the spleen. Slide number 61 is passive congestion of the spleen. Which develops most likely in association with left-sided or right-sided heart failure? Right-sided heart failure. Now, if that is a white pulp, now, although it is not actually white, it is darker than the red pulp, it is called white pulp because it is composed of white blood cells. Now, if that is a white pulp, how will you call that blood vessel associated with the white pulp? Again, the central arteriole or the central artery. Okay, that's another white pulp showing us an almost centrally located central arteriole. Now, our concern here will be in the red pulp. Okay, so as you can notice in that area, the spleen is more dark than the other portions of this slide. So that is so because here, what type of blood vessels are present? What type of blood vessel is present in the red pulp of the spleen? Okay, sinusoids, which are actually dilated capillaries. So as you can notice, the sinusoids in this portion are already filled, almost completely filled with red blood cells, indicating that more blood is accumulating in the sinusoids of that portion of the spleen. So that is the characteristic microscopic appearance of congestion. The red cells will become crowded inside the lumen of a blood vessel. So that is the characteristic change that you should be able to recognize in this slide. Congestion of the spleen. Okay. You will be able to identify that organ is the spleen because of the presence of a white pulp with an associated central artery. Slide number 93. Okay, plasmacytoma. When this neoplasm involves an organ, a single organ only, the condition is called plasmacytoma. However, when it has a systemic involvement, the disease is now called, because, very good, multiple myeloma. So it is called plasmacytoma because it is a neoplasm that is composed of plasma cells. Can you still remember the characteristic appearance of the plasma cells? How will you describe the location of the nucleus? Central or eccentric? Okay, eccentric. If that is the cell, the nucleus should be normally at the center of the cell. However, the nucleus is pushed to one side of the cell, of the cytoplasm in the cells that we are seeing, so that we are able to see a side of the cytoplasm which contains, okay, so parang ma-answeran nyo yan. Anong content ng portion na yan? What is the function of the plasma cell normally? Immune globulin production. So what are the organelles involved in the production of antibodies? Rough endoplasmic reticulum. What will package the produced antibodies? Wow, okay. So that space is now actually occupied by the rough endoplasmic reticulum and the Golgi apparatus that does the pushing of the nucleus to one side of the cell. So what is the characteristic protein, abnormal protein, that will be seen in the urine of patients who will have this condition? Benz-Jones protein. So what will be the characteristic electrophoresis finding, blood electrophoresis finding in multiple myeloma? Presence of? Okay, light change. So that is the characteristic appearance of a plasmacytoma. The plasma cells are seen side by side with each other, so indicating that they are multiplying at a very fast rate. This is why they will be seen in close proximity with each other. Okay, that's the low power magnification view. So a neoplasm composed of plasma cells. Slide number 50 is sinushistiocytosis. Is it a neoplasm or a reactive condition? Okay, reactive. Okay, we are looking at the cortex of a lymph node. So that's the capsule. How will you call those structures pointed? Nodules or lymphoid follicles. So we are now sure that that portion is the cortex because it contains the lymphoid follicles. And then how will you call that space immediately underneath the capsule? Subcapsular sinus. Okay? Subcapsular sinus. And then present in the sinuses of the lymph node are what cells? The B cells and T cells are seen in the lymphoid follicles. How will you call that? Columns of lymphocytes. In the medulla. Medullary cords of Billroot. Medullary cords. And then, these sinuses in the medulla, they are now called medullary sinuses. The problem with this lymph node is the dilatation. of the sinuses as pointed. So those are dilated sinuses, and then zooming in to the dilated sinuses. Okay, we are actually seeing those cells are actually macrophages admixed with few lymphocytes. Orange, eosinophils. So majority of the cells occupying the dilated sinuses are the macrophages. What is the specific name of the macrophages inside the lymph node? Okay, histiocytes. And because they are seen in great number, this condition will now be called histiocytosis. And because they are seen in the sinuses, that's the complete name of the condition. Okay, sinus histiocytosis. This is a reactive condition. Most likely, this will develop from an infection. Okay, characteristic abnormality should be the dilatation of the sinuses and filling with the histiocytes. Itong 51. Nodular lymphocytic lymphoma. What is the other name of nodular lymphocytic lymphoma? Ano? Okay, follicular lymphoma. Okay, sorry. Unfortunately, nag-faint na ang stain nito. That is the capsule of that lymph node, the subcapsular sinus. And then, in the cortex, we should be able to see numerous lymphoid follicles. So, that portion also is exhibiting numerous lymphoid follicles. Now, characteristically, the lymphoid follicles are present in the cortex only. Although there are lymphocytes in the medulla, they will not form follicles, but they will be seen in cords only. Now, when a follicular type of lymphoma, neoplasm of the lymph nodes develop, the medulla will now be seen as having also lymphoid follicles, such as those. So we are now looking at the middle portion of this lymph node. That's the outer portion. It's composed of the cortex. Normally, there should be lymphoid follicles. And then, in the central portion, in the medullary portion, we are still seeing lymphoid follicles, which should not be present normally in the medulla of the lymph node. So that will now be the characteristic abnormality that you should be able to identify. So remember that the medulla is soft because it does not contain any follicle, and aside from that, what imparts that soft consistency of the medulla? There are blood vessels in the medulla. Okay? So we are now sure that we are actually looking at the medulla because of the presence of the blood vessels. So seen immediately adjacent amongst the blood vessels are the lymphoid follicles, which should be absent in the medulla. So that is the characteristic abnormality. And then if you will scan the entire slide, okay, almost all portions of the lymph node will possess or will show lymphoid follicles. Aside from that, another evidence of malignancy present in this slide is that the surrounding adipose tissue is already infiltrated by the malignant lymphocytes in that portion of the slide. Okay? So normally, there should be no lymphocytes outside of the lymph node capsule. We are not even anymore able to appreciate the capsule of the lymph node in that portion of the slide. It has been already infiltrated or invaded by those lymphocytes, which have already reached the surrounding adipose tissue. Adipocytes infiltrated by the malignant lymphocytes. However, the characteristic abnormality that you should be able to identify should be the presence of the numerous lymphoid follicles. Okay, numerous lymphoid follicles not only in the cortex but also in the medulla. So, follicular lymphoma or nodular lymphoma. Slide 57 is acute granulocytic leukemia. Now, we will not be able to diagnose this slide correctly as acute granulocytic leukemia by just looking at the low power objective view. We have to shift to the high power objective view. Now, it will be very difficult to diagnose this slide as acute granulocytic leukemia. What is the more common name of that condition? Acute granulocytic or? Okay, acute myeloid leukemia. So, to come up with the diagnosis of acute myeloid leukemia, you must be able to have a population of myeloblasts, which is more than 20% of all cells that will be seen. Okay, 20%. Now, on light microscopy, high power magnification view, we will not be able to see in tissue preparations which among those cells are the myeloblasts. Now, it will be better to perform peripheral blood smear examination or bone marrow aspiration biopsy, wherein the cells from the bone marrow or from the blood will be seen as smear. So you have already prepared a smear in our microbiology. So ganun pa rin ang procedure paggawa ng smear, i-spread ang mga cells sa slide so that the actual morphology of the cells will be properly studied. We will be able to see the actual morphology of the cells. In tissue biopsy, it will be very difficult to diagnose that slide as acute myelogenous leukemia. So, kailangan ng smear to diagnose this condition. Okay, most likely this is a lymph node infiltrated by the leukemic cells already. Lymph node kasi mayroon siyang capsule. Leukemia is a neoplasm that will originate in what organ? The bone marrow. So actually, wala masyadong delineation sa leukemia from lymphomas. Okay? Kasi, with time, from yung mga leukemia, from the bone marrow, lalabas sila sa peripheral circulation, they will eventually infiltrate the lymph nodes. And then lymphoma naman, cancer cells from the lymph nodes, eventually, they will infiltrate the blood. Okay, para na rin silang leukemia tingnan sa loob ng blood. So that is why, to come up with The correct diagnosis, kailangan ng bone marrow aspiration biopsy, and then there should be also special staining, immunophenotyping, to determine what the type of cells that are involved in leukemia. So have you discussed already the clusters of differentiation of the different leukocytes? Yung CD, CD3, CD4, CD19, CD20. So those markers are utilized to identify the particular type of white blood cell. So take for example, only the B cells will display CD19 and 20, so that they can be identified correctly if a cell displays those two mentioned antigens. They are actually antigens. And then the T cells are identified more correctly because they will be displaying CD3 and CD4. And then the myeloid cells will also display specific CD markers. So we will not be able to diagnose this slide as AML by just looking at this slide. Most likely that slide will not come out in the exam. Number 56. Okay, Hodgkin's disease. What is the pathognomonic cell for Hodgkin's disease? Hello, good morning. Hi, Mon.
Okay. Let's
continue. So what is the pathognomonic? Okay. Reed-Sternberg cells. Now we will not be able to diagnose Hodgkin's lymphoma if the Reed-Sternberg cells are absent. So we have to look first for the Reed-Sternberg cell. Now that's the low power magnification view. Okay, we will madaling ma-identify ang Reed-Sternberg cells because they are larger than the regular white blood cells or lymphocytes. So yan sila on low power magnification view. That's a Reed-Sternberg cell, another Reed-Sternberg, another Reed-Sternberg. So amongst the Reed-Sternberg cell, we will be able to see lymphocytes, and then those orange-colored cells are eosinophils. So the neoplastic cells in this condition are the Reed-Sternberg cells. So yan silang neoplastic cells. Now, what is the characteristic type of RS cells that it will be seen in nodular sclerosis type of Hodgkin's lymphoma? Okay. So those are the lacunar variants of the Reed-Sternberg cells. Now, this is specifically called as nodular sclerosis type of Hodgkin's lymphoma because the white blood cells are arranged into nodules. So that's one nodule. And then that is another nodule. And then the nodules are separated from each other by dense fibrosis. So, pag naging fibrotic ang isang tissue, it will have a hard consistency. So, another name for that condition is sclerosis. So, because the neoplastic cells are arranged into nodules and then the nodules are separated from each other by a dense sclerotic area. So, that's the name, that's the subclassification of nodular sclerosis. So, your assignment is to read the other variants of Hodgkin's lymphoma and the characteristic variants of Reed-Sternberg for each subtype. So, one nodule, within that nodule, we will be able to see numerous Reed-Sternberg cells. Slide 67 is reactive hyperplasia. We will be able to identify this organ as the tonsil because kung yan lang pakita parang lymph node.
Yes.
Okay, because we are able to see lymphoid follicles. However, what type of epithelium is pointed? Okay, stratified squamous epithelium. So, and then this is called reactive hyperplasia because more number of follicles are seen in this tonsil, and then the follicles are not uniform in size. Some are markedly enlarged.